Hello and welcome to the chapter 5. So today we're going to talk about a very important disease actually, and certainly a patient who have the dementia. Well, you will see if you work in any kind of healthcare industry or physical therapy or nursing homes, and you'll see why. It's because dementia is an epidemic now. It's considered as an epidemic, and mostly because the population is aging. So we'll talk about Alzheimer's disease mostly, even though there are many more different type of dementia. Today I'm going to focus on Alzheimer's disease, and I'll explain you also why I'm focusing only on Alzheimer's. So first, what is it? So it's actually, there are a couple of different definitions of dementia in general, but it's obviously a cognitive impairment. So there's a lot of things that can be associated with dementia, and obviously all of them are associated with the brain, with the central nervous system. Dementia is also a progressive disease. Yeah, so progressive meaning that when you start you can't really slow down, and it's also irreversible. The symptoms you're going to develop from the disease are going to stay whatever you are doing. You might actually be able to maybe slow down the progression of the disease, but you can't go back. So it's really a progressive, irreversible chronic disease that lead to cognitive impairment, behavior impairment. Right? There's a lot of different type of dementia, like I mentioned in the title. Maybe you know the most famous, Alzheimer's disease, but there's also vascular dementia, dementia with Lewy body, dementia with frontal lobe type, mild cognitive impairment, which is different than Alzheimer's. But overall, the definition or the pathophysiology behind the disease can be slightly different depending on what type of dementia you have. But actually, the symptoms and the outcome of the disease, of all of those dementia, are pretty much the same. The course of the disease can be different. Some of those diseases can go faster than others to reach some severe cases. But overall, it's really a loss of mental ability that results into those dementia. So a little bit of history about dementia. It's actually pretty interesting to see our understanding of dementia, and that's going to lead me to talk about Alzheimer himself. So that's why it's interesting to see that. So we know the symptoms of dementia even without putting the word dementia on it for centuries. But the beginning of understanding of dementia, and maybe trying to start to understand what it is, maybe starts in 1990s years. So first and foremost, I would say the most important reason for dementia, and what people were understanding, that when people are demented, it's because they are old. So they were associating being demented and being old, which is obviously true. It's because you are getting older that you become demented. But at that point, they didn't make the link with the disease. They thought that it's because you get old that you have a impairment of memory, or you change your mood, or you become aggressive. So they were considering that as normal. Yeah? So it's quite important to understand. And then some scientific at that point, a physician, I would say, were really associating dementia with cause and trying to understand what was going on. So they understood that people who were alcoholic, for example, who were consuming alcohol on a regular basis for many years, had more risk of dementia. Other cause was also a lead poisoning. When you were exposed to lead, then people higher ages were starting to develop dementia. So they started to make those correlation. And we know now that there are relationship between alcoholism, between lead poisoning and dementia. But at that point, obviously they didn't make the connection. They were just saying, okay, the ones who were drinking the most actually had also more risk for dementia. And they also pretty quickly made the link with other cognitive or psychological problems like depression or delirium. Schizophrenia also, being bipolar, was also related to dementia. But you can see all of this was not very precise, and a lot of physicians at that point were still thinking that you become demented because you become old, and there's not much of a relationship. It's not really a biological disease. Until this physician named Alois Alzheimer started to really record and taking notes on case studies and patients he had. So he was very good at that, and he was taking very detailed notes, which is actually the first step to really understand the disease, is to be able to detail the symptoms. So you see here an example of one of his notebook. Okay, so he was writing a lot of different symptoms, and what differentiates him to other psychologists or psychiatric at that point is he also was doing some post-mortem analysis, post-mortem biopsies. So you see here, this picture number one, you see here on the left is where he saw under a microscope looking at the brain of one of his patients, the first patient he saw. So I'll explain the case later, just after. But he also saw this very strange and abnormal black plaques in the brain. So he started to make connection between the symptoms of delusion, aphasia, hallucinations, and all of this, and biology and markers like those plaques or those tangles in the brain. So here's his first case. Her name was Auguste Detter. She was 51 year old. She was a 51-year-old woman, and she was admitted in a hospital in Germany, in Frankfurt, in 1901, and she was a patient of Dr. Alzheimer. She had all the symptoms of severe dementia, with not being able to talk. Very rarely she was able to talk. She was sitting on a chair without much moving. So she had aphasia. She had memory issues. If you look at the picture, she doesn't really look like she's 51. She looks much older, and that's another effect of the disease. So it was really this first case that Alzheimer was able to describe in details. And after the death of this patient in 1906, he did an autopsy, and he examined his brain, and he described all of these plaques and tangles that he could see under the microscope, even though he didn't have access to very fancy systems. But he was able to really describe all of this, and he published an article. That's what scientific are doing to be able to make the public aware and the other scientific community aware of their discovery. So he published an article in a journal, but nobody cared. Basically, nobody was reading this article because at that point Alzheimer was a nobody. He was not known in the scientific community, so nobody really looked at his article until somebody else, Dr. Kraepelin. Dr. Kraepelin was if you want, the most important scientific for psychiatry at that point. And he was really well known for his psychiatry book, who was actually the Bible for all the medical students who wanted to study psychiatry. So everybody knew him. He was a big name in the field. And in his 8th edition of his psychiatry book, he basically described the article of Alzheimer. And he said, wait a minute, this guy just discovered something and nobody really understood how important it was. And he's the one who named the disease Alzheimer's. So he called that the Alzheimer disease. Right? So it's not Alzheimer himself who called the disease Alzheimer, but it's Kraepelin that called that Alzheimer disease. And because he was so famous and his textbook was in every medical school at that point for psychiatry, every student and every other scientist started to be interested in those cases, and they started to run more studies, and that's where basically how our understanding of Alzheimer and dementia in general started to be important. So let's look at some epidemiological numbers now and try to see why this disease is important. So try to see the impact of the disease on the population. And you can see here, around 5 to 6% of the people who are 65 years old will develop dementia. And from 65 to 80 and above 80, you see how quickly the incidence of dementia increase. So more than 50%, depending on the literature you are reading, but between 48 and 50% of the people who are above 80 or 83 years old, 84 years old, will develop dementia. So maybe from a previous generation, being 84 years old or 85 years old was pretty exceptional. So we didn't really have to worry much about dementia. But now, the life expectancy in developing countries is above 80 years old, which means that most of us and most of the people of these generations and the new generations certainly will reach an age above 80 years old, which means that 50% of them will develop dementia. So it's a rapidly increasing disease because of a rapidly aging also population. There are countries where the population is aging even faster than the US. The country that is aging the most and the fastest is actually Japan, and they are very concerned about dementia in general. And why is that important? Because the disease itself has a lot of consequences. It's not a disease that you can easily take care of. Obviously, the loss of quality of life is important for the patient. Okay, so here is more for the patient himself or herself. But also there's a whole array of care that is going to be involved in this patient. So the health expenditure is very important, not only for medication and prescription, but mostly for the care. When you have patients who are unable to dress themselves, unable to go to the restroom themselves, they need 24/7 care. So it's a career burden on the caregivers. Often the families will, and I'll develop that a little bit later, but you're going to have to quit your job if you need to take care of your grandfather or your grandmother who has dementia, because it's such an important commitment. If the families have the money, and if the patient himself have the money, they can also obviously use nursing home and residential care facilities, but those can be very pricey, so it's not accessible to everybody. So here's the different type of dementia, and now I'm going to tell you why I'm considering all the dementia as Alzheimer's disease. And it's actually not only me. So there's many different type of dementia, but looking at the numbers, Alzheimer's disease represents around 70 to actually 80% of the people who have dementia. So if you are understanding the Alzheimer's disease, if you understand the pathophysiology and the symptoms and the treatment, you basically understand the rest of it. And some years ago, recently actually 4 or 5 years ago, the NIH published a report made by really the most important experts in the field. And they basically mentioned that they decided to put every dementia under the umbrella of Alzheimer's disease. And the reason for that is the diagnosis is the same, and the treatment, which we don't have much of a treatment, there's no cure and there's not much of a treatment that can slow down any of the dementia, is also the same for all of them. So why not just call everything Alzheimer's disease, because everything else is we don't understand it as very different than Alzheimer's disease. So that's why I'm focusing on it now. So let's talk about the diagnosis now. How do we know that somebody has Alzheimer's disease? It's actually not so easy, especially at the beginning. On the early stage of dementia, it's difficult. It's usually, so the diagnosis is said to be based on exclusion. Based on exclusions means that there's not much of a definitive test that can say, okay, I'm going to run a blood test and I'm going to tell you have dementia. Let me give you an example that we saw already before in previous chapters. If we consider diabetes, for example, then we know there are markers for the disease. If you look at the glucose in the blood, if you look at insulin in the blood, we have threshold, and we can say, okay, if you're above this 200 milligrams of glucose, then we know you are diabetic. Then it's not the case for dementia. We don't have any biomarkers as of now, and people are really looking into it, where you can say, okay, you have this particular protein in your blood, or this protein is higher or lower than it should be, so you have dementia. So that's not how it works for dementia. Okay, so I'll talk about the diagnosis in more details later on. So here is an interesting graph. I like to use this graph because I think it's very striking. It's really important to understand. So now Alzheimer's disease is the number 6 cause of death in US. So people are it's the 6th cause of death in US. And not only that, but if you look at the trend, so if you look at over the years and over the past 5 years, for example, all of the other, the number 1, 2, 3, 4, and 5 cause of death in US are actually going down. And some of them are going down by a lot, by 20, 30%, because we are better at prevention. So I'm considering HIV, for example, or breast cancer is much better at prevention and much better at treatment. Even if you are diagnosed with a breast cancer, if it's early enough, then you're almost 100% sure that we can cure breast cancer now. Yeah? So if the detection is early enough. Same thing for the cardiovascular system, the stroke, the heart disease. We know the consequences of smoking, of drinking, so all of this is going down. The only one that doesn't go down, and it goes up, and not by a little bit, is dementia. And you see here from a few years ago, dementia was going up by 66%. And so obviously the predictions are within the next few years, 3 or 4 years, dementia will be the number 5. And it's just going to keep going up until it's going to be the number 1 pretty soon. So it's really a problem that we need to take care of. There's actually more than 5 million. There's more than 5 million. Here on the slide it says 4.5, but it was just a few years ago. So there's more than almost 5 million people that have been diagnosed with Alzheimer's disease or dementia in the US. Like I mentioned before, the prevalence is 3% between 65 to 74 years old, almost 20% if you reach 80, and almost 50% above 80 years old. The cost of care is one of the highest in any other chronic disease we consider. It says here $84 billion annually, and it's basically considering not only the money you need to spend to take care of the patient, but it's also the money you cannot make because, for example, you need to drop your job, or because you need to take a job as a part-time job and not a full-time job. So all of those are unpaid hours that are also included in this, and is very important to consider to be part of the disease. So we consider that almost 15 million people will be diagnosed with dementia by 2040, only in the US. The diagnosis is subtle, like I put here on the slide. It's also underdiagnosed most of the time, so it's difficult to diagnose. It's based on all the history of the patient. and the family is very helpful. So the physician is going to run some questionnaires. It's going to ask to do some testing on cognition, from drawing, for example, or remembering some words. You have here the most famous testing from the National Institute of Neurological and Communicative Disorder and Alzheimer's disease. But the problem with those testing, those questionnaire-based testing, is it's only accurate and good at detecting positive diagnosis only when the disease is already severe, when the disease is already well advanced. So it's obviously a very important problem, because in that case there's not much you can do than just taking care of the patient and try to make the life of the patient as easy as possible. So the diagnosis is a problem. The mild stages is where you want to be able to diagnose, so really just before the severe stages. You see here on the sides some drawing testing you can do to see if there's some problem with sensory input, and a classic agnosia. So agnosia is for example, confunding and mistaking a fork for a comb, or a toilet for a cupboard, and so on. So what the patient will be able to sense, for example, will be able to see, actually doesn't correspond to what it is really. So that's what we call agnosia. If the disease also affect different part of the body, different part of the brain, you see here the frontal part of the brain, you start also to have symptoms of difficulty problem solving. All of those more complex cognitive processes, the patient become inflexible, become stubborn, it's difficult to understand abstract concepts, and it's becoming much more concrete. Very often the patient will also have a personality change. Apathy is common. So apathy is really somebody who doesn't talk anymore, who doesn't react much to what's going on around him or her. There could also be a disinhibition. So you can have a patient who all of a sudden is going to undress herself into in a public, for example, a disengagement, not being able to participate in dinner or lunches, not being able to participate in a family life and social interactions. And many other psychotic symptoms can appear, delusions and paranoid symptoms. Some of the symptoms can be associated with schizophrenia too, and so on. Olfaction also is important, and gustatory symptoms. So, for example, somebody is going to eat a strawberry and is going to say that it's a banana, or the opposite, is going to eat a banana, is going to say, oh, it's a nice strawberry. So the mistaking also flavors and smell is one of the first symptoms of dementia. I wanted to put here on this slide what I found in the Alzheimer's Association website. The Alzheimer's Association is the biggest private association in US that is taking care of Alzheimer, and they are really proactive, and they are doing a lot of things. And one of the things they did was to put these 10 warning signs. So when I gotta go into details, okay, obviously in all of those warning signs, and I'm not going to ask you obviously to remember that for the class or for the exam, but here's a couple of examples. So in memory changes, sometimes the patient is going to forget names or appointments, but they might be able to remember them later. Here, some problem solving, making occasional errors when balancing the checkbook, so not being able to do simple additions or subtractions, difficulty completing familiar task, occasionally needing help to use the settings on a microwave, or to have the television working or the TV working or something like that. So you can read that if you are more curious about those warning signs. There's a lot of information on the Alzheimer's Association website, so I would advise you to go there if you want to have more information. The late stages of the symptoms can be very broad, but there's also a lot of neurological signs. So obviously the motor function, the coordinations is going to start to be affected. Impaired gait, impaired balance, the primitive reflexes are going to start to be affected. So you can do ankle jerk, knee jerk, and it's not going to work because of those neurological symptoms. Incontinence is pretty common. Sleep disturbance, mutisms, all of this is part of the late stages and more. Okay, so this is not a definitive list. There's much more, especially for the late stages. So after the symptoms, what do we know about the disease? Why do patients develop the symptoms? It's really this idea. And there are a couple of different ideas, theories behind the pathophysiology of Alzheimer's. So, and actually most of them are quite controversial. Some scientific believe in them and others don't. So I just want to mention the most important, and I have my own opinion on those theories because I've been working myself on Alzheimer for a couple of years. But for now and for you, I think it's just good to have a basic summary understanding of what we know about the pathophysiology of Alzheimer's. So maybe the most important is, so I would say there's two proteins that are known to be important and are known to disturb brain function. The first one is this one, the beta amyloid, or amyloid beta here. It's a protein that is accumulating in the brain, and so it's known as the amyloid beta theory for dementia, and is known to accumulate in the brain and create a lot of different damages. So I'll show you that with a graph later. It might be easier to understand. But that's really this idea of amyloid beta. And there's a lot of scientific evidence to back up this idea. One of the most important evidence is if you mutate the gene responsible for the production of this amyloid beta, then you have the symptoms, and some of the symptoms we know in Alzheimer's. So in animal models, in mice, for example, if you mutate a gene for amyloid beta and make those amyloid beta accumulate in the brain, then they will develop the same symptoms as the humans. Some of the same, not all of them, but some of the same symptoms. So that's one of the proof that this particular protein is important. So here's how it works. Okay, so you see here on top is the APP for amyloid beta precursor. It's let's say this is a neuron. Okay, so this part here is the membrane of your neuron, and inside here is the cytoplasm, and here is the nucleus. Okay, so classic cell biology. On top of your neuron, you have this membrane protein here called APP, or amyloid beta precursor. It's a precursor because this particular protein here is supposed to be cut. You see the scissors here. Actually, obviously, in life, in reality, is not scissors, is digestive enzymes that would cut this precursor and make those small soluble pieces, and that's the amyloid beta proteins. And those soluble amyloid beta are supposed to be cleaned up in the system. They're supposed to be cleaned up from the brain and be removed from the brain. Except that in dementia, and we still don't know why, but in dementia, those amyloid beta are accumulating and creating plaques on top of the brain. Okay, so that's what Alzheimer was seeing when he looked at the autopsy of his first patient. He could see this plaque on top of the brain, and that was made of amyloid beta proteins. The problem with those plaques is by themselves already they're going to start to disturb the connection between the neurons. But not only that, one of the very important aspects of dementia is that your immune system is going to attack those plaques and is going to say there's something wrong with those plaques. Those plaques are not part of my system, so I need to get rid of it. And by trying to get rid of it, the immune system is also going to attack the surrounding cells here. Okay, so the immune system by itself is gonna kill your own cells, kill your own neurons to be able to get rid of those plaques. And there's actually the inflammation process that can be even more deleterious or negative than the plaques themselves. So it's important to understand for the symptoms and maybe for the treatment. Okay, so amyloid beta plaque, that's another. So here on this graph you see a patient with Down syndrome. It's another proof of the theory of the idea of amyloid precursor proteins, because a patient with Down syndrome, they have an extra copy of a chromosome. And unfortunately for them, the amyloid beta gene is on this extra copy. So they are naturally making more of this amyloid beta, more than somebody else. So people with Down syndrome will develop dementia. Almost 100% of them will develop dementia if they reach 30, 35 years old. So they reach much earlier than the normal population because they have this third copy of the APP gene. I mentioned the transgenic mice before, so they have learning and memory deficits, and that's really what you really need to understand about the amyloid beta. So you see here, I like this graph, okay, because this graph is kind of very simple and easy to understand. So this is a brain, okay, and in your brain you have different type of cells. You have neurons, you have glia cells, you have many other different type of cells. That's what it. But here there's only neurons represented, okay, and in between neurons there's also other different type of cells. So in a brain of somebody who has Alzheimer, you would see plaques. So you see the plaques here are made with amyloid beta, and that's the one I mentioned before. And those plaques are usually between the neurons. Okay, you see they are between neurons, and that's why they start to disturb the synapse. They start to disturb the connection between neurons. The second protein and the last one we're going to talk about is actually a protein that is on top here. You see on top of the neurons, and creates neurofibrillary tangles. This protein is called tau, T-A-U. Okay, this protein is called tau, and it's the phosphorylation of tau that creates the neurofibrillary tangles on top of your neurons. Okay? So you see at the end, for a brain of Alzheimer, you have plaques between neurons that disturb the connection between the neurons, but you also have neurofibrillary tangles on top of the neurons that are actually going to start to kill the neurons themselves. And so you have here this schematic representation of the disease. You have on top, let's say this is 1 and this is 2. You have on top of the graph, you have a normal brain that has nice connection between the neurons and nice neurotransmitters that can flow from one neuron to another. And that's how your memory, your executive function, your problem solving skills are going to be able to work. But here on number 2, at the bottom, you see there's a whole damage area for the brain because of your immune system that is trying to get rid of the plaques, trying to get rid of the neurofibrillary tangles, and then there's no more connection between those neurons. So you still have maybe some connection here at the bottom, but you see in between there's no more connections, and that's what makes the difference. That's what makes the relationship with the symptoms we just described for dementia. So what are the risk factors? Actually, there are not many risk factors that have been really well established in the literature. The only one that is really clear is age, which means that as you age, as you get older, you get a higher risk of developing dementia and developing Alzheimer's disease. Being a female seem also to be a risk. But it's obviously difficult to differentiate, because being a female also means that you live longer than men. So is it because you live longer that you develop more dementia, or is there really something physiologically relevant of being a female that put females more at risk? And yes, there are a lot of literature on the effect of menopause, for example, and the change in hormones and the endocrine system that may affect women more and put them more at risk for dementia compared to men. And there's also what we call a family history of dementia. Like I mentioned before, there's around 10 mutations, 10 genes that have been associated with dementia. So we don't need to go into details about those genes, but you need to know that there is a family history. So it means that if you have a grandmother who were developing dementia later on in life, maybe you have this predisposition, and maybe you are at higher risk of developing dementia. And then there's a lot of other things in the literature, but I would like you to really take this with a grain of salt, really, because these are just correlation, which means that there's not much relationship, cause and consequences between, for example, having a low intelligence, a limited education, and developing dementia. Having a chronic depression, having hypertension, having diabetes, smoking, all of those, head injury, concussion, for example, is pretty clear that there's a link with dementia, but it's not very well established yet. Okay. At the opposite, same thing, trying to understand what puts you less at risk, so trying to reduce the risk of dementia. There are some correlation in the literature. So for people who have a college or higher level of education, seem to be more protected from dementia. The Mediterranean diet, with wine and having more fish than meat, and having this unsaturated fat with olive oil and so on, seem also to be related to a lower risk of dementia. But that's, again, not really well established. It's difficult to test. Actually, to really test that, you will need to test people over a period of 20 years, for example, or more, 40 years, to be able to see the effect of that. So one of the hottest topic in dementia now is imaging, and being able to scan your brain and see if you have dementia or not. So I just want to show you here, in one, you have a normal brain, and in two, I would say 2A here, and 2B here, you have a brain with dementia. So there's a couple of things you can see. First, if you compare the normal brain to the brain with dementia, you can see here the extremely large ventricles, which means that there's space, that the brain is losing matter, basically. So you are losing neurons. You can even see it here on the sides. You can see there's really a shrinkage of the brain compared to a normal brain. And what you see in 2B here is actually the glucose. We'll put that here, the glucose uptake. The brain is only taking glucose as a substrate. So if you are looking at the glucose metabolism, you could actually see how active your brain is. Okay? So, for example, if you ask the patient to read something, and reading is actually a very demanding effort for the brain, you're going to see the brain is going to light up in red if you look at an MRI, because it's a very complex cognitive process. And you can see here, for somebody who has dementia, there's only this few parts here that are lighting up in red, showing that activity of the brain is sucking up glucose because the brain is active. If you were doing this with a normal brain, the whole brain would basically line up in red, almost, because reading is difficult. So you see here that the brain can't be active anymore. He's losing all of these connections, and is losing cognitive capacity. There's not much of a treatment, or here not much of ways to help or to slow down the progression of the disease. I put here the role of exercise just because that's us, basically, and we are exercise physiologists, and there's a lot of literature actually saying that maybe exercise is helpful. If you exercise throughout your whole life, you might actually really prevent dementia. And there's, again, it's very difficult to test, but there's pretty clear evidence on that. But there's only 5 drugs on the market now that have been FDA approved for dementia, and none of them are really working. They have an extremely limited efficacy. So like I put here, basically they have around 6 to 12 months of an effect. It might feel a little bit better, or the symptoms might slow down for 6 months to a year, and then the patient keep taking those medications and there's no more effect. They just go back to the regular progression of the disease. So there's nothing really on the market for dementia in general and Alzheimer's disease in particular. But people have tried. So you've heard about a lot of different things, I'm sure, in the literature, using brain games to try to make your brain active and try to see if that could prevent dementia, taking some supplement and try to have some antioxidant, anti-inflammatory supplement, trying to increase the blood flow, using medication like the Viagra, for example, to increase the blood flow, and to see if that could also increase the blood flow in the brain and make the brain works better. But none of them worked, basically. One of the most anticipated drug was this anti-inflammatory drugs, because I told you before, the immune system is involved, and if you are able to control the immune system, maybe you can control also the progression of the disease. But actually, all of the trials that was working on anti-inflammatory drugs basically failed because it worked in animals, actually, in mice and in monkeys, but it failed pretty dramatically in humans when they try to do that. The patient were dying from encephalitis, so from a chronic overall inflammation of the brain, even though they were taking anti-inflammatory medications. Okay, I'm going to pass on that. So I always have this question about, since there are genetic predisposition, should we be tested for Alzheimer's disease? And what if the test comes back positive? So obviously this is an individual decision. Everybody is obviously free to have this, and it's quite easy now to be tested if you want to. You can just get a kit from the mail and then get some rub a cotton swab into your mouth, and then get some cells and get your testing done. But if you think about the consequences of the testing, so either it comes back negative, you don't have any mutations, and you're going to feel that you are okay, but actually there's more than 80% of the people who have dementia that don't have a mutation on the genetic. Only 20 or 15% of the people with dementia have actually a genetic mutation. So if the test comes back negative, then you still have a pretty big chance actually to develop dementia. And if the test is coming back positive, then you're gonna panic maybe and say, oh, I'm gonna have dementia, but actually it's not because you have the genetic mutation that you will automatically get the disease. There's a lot of people who have the mutation and will never develop the disease. But what is this positive test is going to do for sure is for you to be stressed out and for you to maybe take actions. So it's very difficult to advise somebody to take the test or not because of that, I think. So that's it, what I wanted to talk to you about for dementia today. We went pretty fast on that, but I just wanted to give you an overview, a brief summary of what dementia is. I would really advise you to look into it if you are interested, because there's a lot of jobs out there that are associated with taking care of patients with dementia, and it's not going to go anywhere. We're going to have opportunities for, hopefully our understanding of dementia is going to increase, and we're going to have a lot of other opportunities to help those patients. So I would really advise you to look into that if you're interested. And with that, we're going to conclude our chapter for today, and we'll see next time on how we're going to be able to see a case study. Okay, thank you.